I wanted to do is just talk generally about pNETs and paragangliomas, just because they're very fascinating diseases to kind of dig deep. The more you dig, the more you understand and learn. So they're really complex entities. So let's talk a little bit about what makes pancreatic tumors, a little tiny organ that we don't ever talk about or think about, and all of a sudden can cause problems. There's two types of general cancers of the pancreas. One is the adenocarcinoma, and that one is what we call from the exocrine portion of the pancreas. That's the most common type of pancreatic tumor, 60,000 cases a year. The other one that we're concerned about today are from the endocrine side of the pancreas. So the pancreas has an endocrine function and an exocrine function. Now, the endocrine function is really, it secretes hormones, a lot of hormones that we take for granted, insulin, glucagon, etc. And when you have tumors of the pancreas, a lot of times the tumors themselves will secrete these hormones because there's tumors of the cells that make the hormones. So this is one of the reasons why I really enjoy taking care of neuroendocrine tumor patients, is that when they have a functional syndrome, when they have a tumor that makes a substance, it really adds a complexity, and you really need to kind of dig deep and understand what's going on. Now, a lot of different neuroendocrine tumors make hormones. So the midgut tumors, they make serotonin, and that causes what we think of carcinoid syndrome. Now, pancreatic tumors and stomach tumors can sometimes produce gastrin. Those are called gastrinoma, sometimes Zollinger-Ellison syndrome, named after those doctors. Glucagonoma, right? You can make glucagon or enteroglucagon, and you can have a glucagonoma. And a lot of times patients will have a really unusual skin rash, and that's how we'll figure it out. Some tumors make insulin. Insulin will make your blood sugar go down, and that's a problem. Some tumors make pancreatic polypeptide, and that can cause issues. They call them a PPOma. I don't know if you've ever heard of that one. There's somatostatin-producing tumors, somatostatinoma, and there's VIP or vasointestinal peptide-producing tumors that are called VIPomas. VIPomas are on every single board exam for GI doctors. So they all know about VIPoma, but they might not recognize it when it comes into their clinic. But on paper, on a multiple choice question, they're good at diagnosing it from the achlorhydria, actually. So one thing that's not on this list, and you can't find a lot of it, is that, did you guys know that paragangliomas and pheochromocytomas are technically neuroendocrine tumors? And does anyone know what type of hormone they produce? Esther?
It's cortisol, right? Metadephrine?
Oh, epinephrine, good. Yeah. So there are tumors that you're good. You got two different syndromes. Some tumors can produce cortisol. We call them Cushing's disease. Yeah, absolutely. A lot of lung neuroendocrine tumors do that, occasionally pancreatic. Yep, they'll get swollen, hypertensive. But the other one you said, the metanephrine, absolutely. Catecholamines, metanephrines, norepinephrines. It's a syndrome that's very important. And it's so funny is that we have this whole world of neuroendocrine diseases that we all share together. But a lot of times the doctors and the patients with the pheochromocytomas, which is really an adrenal neuroendocrine tumor, it really is the same thing. They're in a different world with endocrinology. So they have their own parallel universe. One of the reasons why I wanted to discuss this today, because I feel like we have to bring our worlds a little bit more together. So this is another interesting issue that we don't really talk about too much, is that a lot of neuroendocrine tumors can be inherited. And it's hard because a lot of us will notice that we have a family history of it, but no one can really explain the connection. Well, here are the syndromes that we do know about, that we understand, that we've described. These include MEN1, MEN2A, MEN2B, and the list goes on and on. Now, a few of these that are very interesting for today's topic is the VHL, or Van Hippel-Lindau. This is a genetic disorder that leads to the development of pancreatic neuroendocrine tumors. Many of these other syndromes also, but VHL is important because there's a new medication that was recently approved for patients with VHL-associated pancreatic neuroendocrine tumors called Belzutifan. That's a mouthful, but we'll talk a little bit more about it. Other syndromes that are interesting is when you go down, familial paraganglioma 1 to 5, familial PCC and PGL. So a lot of paragangliomas are inherited, about 35% of them, if you can believe it. The rate of inheritance for other neuroendocrine tumors way, way, way lower. So you might notice that some of the paraganglioma patients that you meet will be on the younger side because, again, they inherited a gene defect that predisposes them to develop these tumors. Now, a lot of times, paragangliomas, and Lisa knows this because she's involved in the cutting edge, they are treated in the same but different. So it's like we do something for pNETs and then we try it in paragangliomas. It's kind of like trailing pNETs because of just its rarity, the people who treat them, even though they're biologically very similar, they're in different families. So paragangliomas a lot of times are seen by endocrinologists. They're also seen by different types of providers, surgeons a lot of times, etc. But very important to know that SDH A, B, C, and D right here, these are very important genes that lead to paragangliomas. A lot of times when you have a paraganglioma, you can actually look to see whether or not you're missing one of these genes to see if it's a higher risk for having a family gene issue. So paragangliomas, let's talk about them. So there are about 1,000 to 2,000 patients a year, not a ton. 10% of pheochromocytomas and 25% of paragangliomas are considered malignant, and up to 35% are hereditary. So that's really interesting. All right. And again, the treatments are being developed. They're being better understood. We use a lot of the same ideas for the treatment of paragangliomas and pheos that we use in neuroendocrine tumors. We use gallium-68. You can try Lutathera. You can do SSA. But there's also a lot of different approaches to those tumors. Pheochromocytoma patients, because of the norepinephrine and epinephrine, they'll usually have an endocrinologist or a cardiologist manage their blood pressure and their pulse. Also, there's a lot of different surgical considerations for patients such as that. So again, they're overlapping, but not exactly in the same family. Now, pNETs, there are about 600 to 1,000 of advanced pNETs who progress, it says here, but there's a few thousand a year. They're mostly sporadic, about 10% are hereditary. So like we talked about 1 out of 10 patients with pNETs will have a family gene, and 3 to 4 out of 10 of paraganglioma as well. Okay, and of course, most of us are very familiar with the standard treatments for pancreatic neuroendocrine tumors, and I won't get too much into that. So Belzutifan is a very interesting medication. It blocks something called HIF2 alpha. It basically, what ends up happening in a lot of tumors is that they have a problem with Van Hippel-Lindau gene. That leads to an effect where there's a lot of proliferation. This thing over here, this cycle that you see, starts churning much quicker than it's supposed to be. HIF2 alpha kind of breaks this process. Now, patients who have a defective Van Hippel-Lindau, there are many ways to get that. One of them, you can inherit the gene, but a lot of pancreatic neuroendocrine tumors and a lot of paragangliomas have defective VHL because the tumor itself is defective in the tumor. So when Belzutifan was used for patients who have VHL, we found that there was a pretty good response rate in patients with pancreatic lesions, up to 65%, which is really quite high. And if you had a neuroendocrine tumor of the pancreas, the response rate was 80%, which again is pretty high when you're looking at cancer trials. Now, the FDA, based on this data, approved Belzutifan for use in patients with VHL-associated tumors, including pNETs. So it's already approved if you have VHL and a pNET. And the side effect of this, the main one is anemia, because the same process by which it stops the churning of that pathway I discussed, also one of the side effects is that it stops your blood cells from churning out also. So anemia is pretty common, although it's not usually severe. So grade 3 is when we consider it significant, usually not too much of grade 3. Now, why do we think that this medicine might help in paragangliomas and pNETs? Well, there's a lot of science, some of it that doesn't make enough sense for me to describe to you, but there's enough science there that paragangliomas and pNETs both have alterations, we call them, or mistakes in that pathway where hypoxia induces tumor growth and tumor proliferation. So it's been one of the things about cancer care that we always notice that when you look at a tumor, it looks like dead and necrotic inside. And a lot of people have thought that that is a clue that somehow this hypoxia-inducible factor pathway plays an important role in the ways cancer grow and spread Because when you think about it, something that's dark and blah in the middle shouldn't really be doing well, right? That should probably stop growing and go away. If you think about it, why does that dark blob keep moving and growing? A lot of people think it's hypoxia-inducible factor. So you have hypoxia, this factor comes into play, and there's pathways downstream that start to get stimulated. So it's been a very big idea in cancer care for decades. So this is finally, through developing this antibody to HIF2 alpha, it finally seems like we're getting somewhere with this concept. So this study, it's an international phase 2 trial. So the dose is pretty much set. It's international, meaning that the way that it's designed is that I'm guessing that it's going to be a single arm trial that then gets sent to the different regulatory agencies for drug approval, by the argument being this is a rare disease. It has activity in patients who've already had treatment. We don't need to compare it to placebo. We know it's working because they're getting responses, they're doing well, and probably the right thing to do is get it approved. So that's how these trials are designed. That's why they're international, because if you're international, you can ask each country that's participated their associated regulatory agency. So European countries, you have enough patients in Europe, you can go to EMA. In the US, you can go to the FDA, etc. That's why it's being done this way. There'll be 70 patients per each arm are going to be accrued. I think already there's about 50 in each arm. So what was really fascinating about this study was that a lot of patients with paragangliomas started to get enrolled. Everybody thought that that would take the longest time, but that's been actually enrolling more quickly, because I think the paraganglioma community also is pretty tight, like the NET community. They've been talking and they're getting excited and getting involved. So everybody gets the medicine. It's a pill. It's getting dosed daily, and they do scans every couple of months. Pretty traditional study design. And the objective is really to see if it's working. We call it objective response.